to go. Right. Okay, I think we're all good to go now. So it's currently 9 o'clock here in Sydney. I'm not sure what time it is wherever you are around the world, but welcome along to this IHN webinar. Before I go into the slides, just as is traditional here in Australia, we have what we call an acknowledgement of country. So I begin today's meeting by acknowledging the traditional custodians of the different lands where we have gathered today. I'm speaking to you from the lands of the Darug people of Western Sydney. I pay my respects to the elders past and present, for they hold the memories, the traditions and the culture and hopes of Aboriginal and Torres Strait Islander peoples across the nation. So this is the webinar from IHN focusing on partnering with patients for safer transfusions. So a bit of housekeeping. Your microphone is muted by the host and will remain muted throughout the session. If you do have any questions, we'll certainly answer those at the end of the 3 talks. But there is a Q&A box, which you should notice at the bottom of your screen. So if you do have a question, please type it in to the Q&A box and not the chat. And we'll be monitoring the Q&A box so that we can answer them either through the Q&A at the end or live as we go. Live captioning is now available during the webinar, and attendees can switch this off if it's not needed. You should on screen see where that is. And at the end, the session will finish with a poll for your immediate feedback. And attendees are encouraged to record their learning from this session and can enter 1 CPD point from this webinar. So thank you for attending. So next slide, please. So thank you very much certainly to Darren and Raquel from SHOT, who are holding our hands through the process today. That's always very much appreciated. Thank you to Stuart, Anna and Shruti for agreeing to come along and talk. And obviously thank you for attending, because obviously without you attending, we don't have a webinar. So thank you each and every one. And this is the outline for the webinar today. I'm just doing the welcome and the housekeeping. And then shortly I'll be handing over to Dr. Barbie Whitaker, who will provide a welcome on behalf of the IHN board. And then we have 3 excellent speakers. So Anna Manuel, who's the Patient and Public Involvement and Engagement Officer for NHSBT and part of Transfusion 2024 Patient Public Involvement. Second speaker is Stuart Lord, who's the lead transfusion practitioner for Gloucestershire Hospitals NHS Foundation Trust. And the final speaker is Dr. Shruti Narayan, who's the Medical Director of SHOT and the IHN President. And as I say, at the end, we are aiming to have about 15 minutes or so of questions, which all the panelists will be available for. And then at the end, we'll have our poll for you. You might be keen to know that the IHN has an app, which is now freely available to download either from the Apple or Google Play stores. You can search for IHN or scan the QR code, which you will see on the screen. And this gives you instant access to resources, links, and events on the IHN website. And if you can, it would be much appreciated if you can share this widely, because we would like to spread the IHN app as far as we can. And this is really quite exciting news on behalf of the IHN and the IHN Seminar Committee. We can announce that the spring webinar, because that's the European spring, the spring symposium, I should say, not webinar. We're planning to hold that in Rome in hopefully around about March next year. At this stage, planning's just really kicking off and getting into gear. So further details will follow as they become available. But that's really exciting. So Rome next year, 2026, for our spring symposium. So I think now I can hand over to Barbie just for the, not just for, but hand over to Barbie for the introduction from the IHN board. Over to you, Barbie.
Thank you, Simon. Welcome, everyone. Good morning, good afternoon, good evening, and thank you so much for joining from all over the world. We really enjoy having these interactions in a webinar version, and on behalf of the International Hemovigilance Network Board of Directors, I'd like to welcome you and encourage you to engage by asking questions, putting them in the Q&A section of the webinar. And it'll be a great opportunity for you to interact with our three speakers. We are committed to providing webinars twice a year, and we're also, as Simon said, very excited about our spring symposium, which will be held in Rome in at this time, it's planned to be in March 2026. So without further ado, I will pass this along to our first speaker, Dr. Anna Manuel.
Hi, hello everyone, and I'd like to also say thank you for joining today. And it's great to have so many people here to hear what I've got to say about patient transfusion safety and what that means to patients. So as I've already been introduced, I won't go through that again, but I wanted to kind of start with firstly sort of say, hopefully I'll give you a bit of an insight into the patient perspective and involving patients in things like transfusion and the value of it and the impact of it. And also, again, before I start, I wanted to also mention that when I'm working with patients and the public in the UK, one of the things I get asked a lot is there any global collaboration? So obviously I'm really pleased to pass on to them that there is lots of global collaboration, because that's really important to patients and people in the UK, that we are all working together globally as well as in the UK. So just quickly, want to give you a reminder that behind every unit of blood, next slide please, is a real patient, and that is me there. So also, as well as the role I do now, I was diagnosed with acute myeloid leukemia 10 years ago. So that kind of gave me a big patient experience, threw me into a whole different career path. And really, I like to just kind of share this, because it highlights that transfusion is more than just physical and more than numbers and things like that. It is actually, you know, someone's life, quality of life. And the message on the screen you're seeing at the moment was from my sister, because basically during my really grueling treatment, I hadn't really been very communicative with my family or anyone. So having blood really did help. So this really is to highlight the fact that she'd sent me a message and I'd responded back saying, joke, I feel like a vampire because I was having blood. So that just highlights the impact on a personal level, and my family was so happy to hear this. So I just wanted to kind of like really start with that. So next slide please. Okay, so again, like I said before, it extends beyond the medical to the personal. So from my experience and those that I hear from, everything that you experience on your patient journey, if you want to call it that, affects how you live, your quality of life, your survivorship. So it may not feel like a big thing at the time, a big impact at the time, but all these things, believe me, do have a massive impact on you and how you live your life going forward, the good and the bad. So every transfusion matters, which I'm sure we all agree with. Next slide. So why do we need to understand lived experience? What's the point of it? You know, why do we need to be asking these questions and working closely with patients? It basically, you know, ensures that care is more compassionate and patient-centered. So we like to say and think that we're patient-centered, but we need to be actually interacting with patients more closely to understand if we're actually doing that, you know, from a patient point of view. So it can uncover anxieties that we might not be aware of as professionals, and we may make assumptions about what we think is important, but actually we need to understand what is important and what it all means to people in order to match what we're doing to that. And patients, you know, it's important that they feel listened to and valued as users of the service, rather than, you know, sometimes the negative things that we can hear from people, negative feedback. So it basically improves the emotional climate of the transfusion environment, supports a positive safety culture, and where both parties can sort of speak up. Next slide. So this is about like minding the gap, and this is a reference probably only people in the UK will get, because you know, when we go on the tube in the UK, there's a voice that tells us to mind the gap, and it's a safety warning. So I think this kind of like came into my head because it's sort of similar with what we're trying to do with working with closely with patients on designing services and on safety and things. It kind of humanizes the numbers, so it bridges the gap between transfusion and the person. So the clinical view versus the patient view. For example, clinical view is 1 unit of red cells, means a hemoglobin increase, but to a patient, it's like more energy, hope, survival, feeling safe. So, you know, it sort of like gives us that check on how transfusion care actually feels to the people that we're interacting with. Next slide. So basically, I sort of thought, you know, how we do all this, like all these meetings and all these webinars and symposiums, all the thing about what we want and how we think things should look. But how do we know if we're getting it right? How do we know it's acceptable and appropriate for those people we're actually wanting to reach? So this is where obviously patient lived experience comes in, and patients with lived experience recognise a acceptable and appropriate service as something that feels safe, is understandable, respectful, and responsive to their needs. So by getting continuous feedback and having that continual involvement, then we can gain strong evidence that we are doing the right thing and it's effective and appropriate. So that's one of the values of patient involvement. Next slide, please. And actually, I've done a lot of patient involvement work over the years, and over the last couple of years for NHS Blood and Transplant, we have a patient involvement group that we've done quite a bit of work with. So one of the things that came up as a top priority was safety. So obviously that's good to know and good to hear, because that's something that we're also feel is important. So therefore we are actually, you know, hitting the right thing there. But what does safety mean to patients? So what safety means to organisations and clinical staff, is that the same as what it means to patients? So I just wanted to add this in here. You know, patients often describe feeling reassured but anxious. They believe that NHSBT is careful, but they worry about issues relating to staffing and digital systems and priorities. Patients want to be sure that blood is rigorously tested, as far as donors are concerned, that process is safe and ethical, and that there's robust systems in place, such as SHOT, so that ensure the safety. So just a quote there at the end there from a patient: I don't worry about where it comes from, I just want to know it's being checked and it's safe. Next slide, please. So why is partnering with patients the key to safer transfusion? And that what this actually means is working with patients rather than for them. So it's getting that into our heads that we're not doing something to them, we're doing something with them. So it's very much that. And also I'll always like to mention that, again, from my experience, I was a healthy and fit and healthy, never ill 39-year-old. All of a sudden, my life massively changed to be really reliant on NHS services. So that highlights that it really can happen to any of us at any time, or our loved ones, or anyone like that we really care about. So how would we feel about the service if that was, you know, if we were in that position? So we need to remember that we're all patients in some way. Okay, so some of the benefits here is that, you know, of why this is key is that it signals that speaking up is welcome, reducing the hierarchy that can sometimes silence staff and patients, and breaking down those barriers and making people feel more comfortable working together, really. So it's about, I feel, you know, about patients and clinicians working more together as a team. So it supports a learning culture rather than a blame culture, improves the emotional climate and in the environment, which supports positive safety culture where both parties can speak up. And again, staff feel supported rather than challenged. Next slide, please. So what we heard, what I kind of mentioned earlier, that we've done quite a bit of patient involvement around this, is that patients do want to play a role in their own transfusion safety. So I thought this is worth covering. You know, patients want to have a role in their own safety. They want it to be more of a safety partnership rather than being passive recipients. So things like, you know, perhaps safety checks, confirming IDs, reporting symptoms, and understanding what to expect. So being like more in control of your own destiny in a way. And I can really, you know, advocate for that as being a patient in that situation where that didn't always happen. So to be part of the safety partnership, creating a shared responsibility for harm prevention, so patients can be responsible as much as, or not, maybe not as much as clinicians, and continuous involvement, continuous feedback. And they want to see like that they've had a visible influence on how a service works. It's not just kind of a bit like what we call, say, in the UK, lip service or a tick box. So it is important to know how patients really feel and not to make assumptions, because we all make assumptions. I think it's human nature. We assume something's working well when maybe it isn't, and it maybe just needs to be tweaked. And the only way we would know that is by asking the people that are actually using it. Next slide, please. So these next slides are a little bit busy, but hopefully, I don't know if I assume these slides are going to be sent out afterwards. So just really to highlight there some of the key aspects of patients and, you know, being involved in making transfusion safer. So empowered patients will understand why they need a transfusion and what to expect and how to prepare. And it also will help prevent misunderstandings and less anxiety for everyone and smoother workflows. Next slide, please. Again, another busy slide, but I thought this was all important. This is going into a bit more detail. So it will, you know, empowering patients in transfusion safety means they may ask more questions when something is unclear, so better communication, adhere to pre and post transfusion instructions, and again, building trust and mutual learning. So it basically helps staff confidence that safety protocols are understood and followed, reducing avoidable incidents and the emotional toll of near misses. Next slide. Passive versus active. I wanted to just really quickly run over this. So this is why, you know, patients want to be more an active patient rather than a passive. So there you can see that why being passive is a little bit more detrimental versus being the active patient. So that I thought was important to cover. Next slide. And just to really highlight that patients gain a lot out of being involved too. So we found that doing with the strategy, patients actually had a really increased understanding of the complexity of transfusion systems, greater appreciation for the diverse roles within the workforce, deeper insight into the technical aspects of blood matching and things like that, and then being heard and part of the solution. So this also helps us when we're trying to do things, because if they understand more, then we're going to work together better. Next slide. Yeah, that just brings us to the end now, and I think I've kind of used my time up. The next couple of slides just really to highlight that how we've listened and worked together with patients, and the My Transfusion app is something that we've done. It's been a great success, so really happy to share that. And that brings me to a close, really. Thank you.
Brilliant. Thanks, Anna. That was fantastic. Great insight into the patient perspective. In the interest of time, we'll go on to the next speaker, which is Stuart Lord. And Stuart's the lead transfusion practitioner for Gloucestershire Hospital's NHS Foundation Trust, chair of the South West of England Transfusion Practitioner Group, and member of the National Transfusion Practitioner Network, and also TP group member for the BBTS. So over to you, Stuart.
Thank you, Simon, for that introduction. And again, hello to everybody who is on this call or listening to it afterwards. So I'm just going to hopefully complement what Anna has expertly talked about why it's so important for patient engagement in transfusion safety. So I'm just going to sort of enhance that a little bit or go off on a tangent from a hospital perspective. So next slide, please, Shruti. So my talk, I'm going to cover just these following 5 points. So I'm just going to hopefully describe opportunities within a hospital to engage patients. Anna's sort of covered a lot of that already, so I can whistle stop through a few of my slides. Just a couple of case studies or initiatives that I've done from a personal experience within the organization I work for, in regards to empowering and engaging patients. I can't help with any talking that I do talk about patient blood management. It's a huge passion of mine, so I'm linking a bit of patient engagement and empowerment as safety in regards to patient blood management. And then finally, I just wanted to really conclude how it's also important for organizational safety, not simply transfusion, albeit it's the most important for us in working in transfusion medicine, but actually a lot of the initiatives and guidance, it translates across the whole breadth of healthcare. So Anna has expertly covered this slide, and I was hoping she would, which means I can sort of gloss over it quite quickly. But I just wanted to sort of highlight why it is important for patient safety. And like I said, Anna's explained this, but in terms of haemovigilance as a transfusion practitioner, I'm involved in a lot of incident investigations where things do unfortunately go wrong, and either harm or potentially harm could have happened to our patients. And often I find that the patient's voice is actually sometimes what is how we find that out. And the concept of patient engagement, when I first started learning about that concept, initially my ignorance possibly was the fact that I thought this was about patient satisfaction, which is important, and we should be making sure that patients are satisfied with the care they're receiving. But actually, it was much more complex than that, and it's a frontline defence within our transfusion safety system. So again, reducing errors, promoting awareness, it builds trust, which Anna has expertly described, and it can improve outcomes from engaging our patients in their care. I'm a scientist by background, and I can't help, whenever I'm talking about anything, weigh up the pros and cons and analyze processes and concepts that might be being introduced within healthcare. I have to say the pros definitely weigh out the cons with patient engagement, but it's just something I certainly have seen when I've spoken to patients before. And the one I sort of just wanted to mention is that engagement with patients, and that some patients actually might not want to be actively involved as another patient. So it's very patient specific, and we need to be really conscious of that. I can't speak for Anna, but there might have been days when she was going through her intense treatment for her acute leukemia, where she just wanted to lie there and have whatever she was given to make her feel better. And I'm sure there's other patients like that. So there needs to be a little bit of care when we're involving patients in safety. Because I know, for example, some of our staff, when I've gone into our teams and said, right, how can we, help involve patients in improving the safety of our transfusion system? And a lot of the professionals think it's not really for the patient to do that. As registered practitioners, as doctors, as nurses, midwives, all of us working in healthcare, that's our responsibility to do that, and it really shouldn't be the patient, which I understand why that's coming from. But and trust is the foundation of healthcare, and patients should feel confident in our expertise. But even the best systems and professionals are immune to human error, and all the human factors that are involved in when things go wrong. So engaging patients isn't about shifting responsibility, it's about adding another layer of safety. And that's how I try and pitch it when I'm talking to our members of our team. So next slide, please. So I've just sort of, again, a bit of a busy slide, so apologies for lots of words, but I just wanted to list a few opportunities that anyone working within a hospital environment can sort of use, if that's the right word, to engage our patients. So these include pre-transfusion education. So there's lots of tools out there, especially in the UK, and I'm sure there is around the world. So information leaflets, videos and apps, which Anna's just mentioned. I've got another slide on the app shortly, explaining what's going to be expected, what transfusion is actually needed. How can you as a patient actually tell someone that you don't feel quite happy with something that's been said or something that's going to happen, and you want to ask it? Because a lot of patients could be quite scared, and they feel that they just want to go with the flow and get on that treadmill of healthcare, but actually they sometimes need to stop and ask some questions. And how does that actually happen, and how does that work? Obviously, bedside identity checks is one of our critical steps in transfusion. So I've put sort of inviting patients to participate. So obviously, we do a lot of education about not interrupting the safe bedside check when you're checking blood components, which I fully agree to and abide by. But in making sure that patients know what that safe bedside check is, what is that check? What does it involve? And if something is missed, could that patient saying, oh, actually, you've not checked my wristband? So just little things like that can really help. Feedback mechanisms, so again, linking to that satisfaction. So surveys, interviews, whichever things you think appropriate that we can feed back and improve our system. And then involving patients in meetings and committees. So I've got a case study or a local initiative that explains that much better shortly. Next slide, please, Ruthie. And then digitalization. So we're in the digital world, and digitalization in healthcare is coming on leaps and bounds, which is great. Comes with a bit of a headache for us working in healthcare, I'm sure, with implementing these digital tools. But I couldn't not talk about patient involvement and opportunity to engage patients without talking about the app that Anna just alluded to, that was designed by patients for patients, in accompanying with the serious hazards of transfusion team. And it's a absolutely fantastic tool here in the UK that we're hoping to really push to improve digital information out there to our patients to improve safety awareness. And I can't wait to see how it's going to work in our hospital. I speak obviously from the UK here, that NHS England have produced a framework for hospitals that actually outlines clearly a government-derived framework that spells out how to involve patients in their own safety and what to do as an organisation. So again, anyone who is on this call around the world, see what your countries and governments have actually published in terms of frameworks to really help bolster you implementing these within your hospital or organisation. I just wanted to really quickly talk about a case study, just to highlight how patient involvement is really important. And this is a case study that actually happened within our hospital that I investigated. This was a transplant patient that we had here. They'd had an allogeneic hematopoietic stem cell transplant. And this occurred at our transplant centre, which is a different hospital to the one I currently work in. They were blood group A, and they received a donor blood group of O. They then returned to us. The transplant worked, and it was fantastic. So they got discharged back to us as her discharging hospital, or referring hospital, sorry. And in the transplant centre, they had a really good mechanism for empowering and educating their transplant recipients about how complicated their blood group may be, and what they should be receiving when they are discharged back to another hospital. And when she arrived back here, she did actually need a blood transfusion, and she received APOS red cells, which, in accordance with the guidance in the United Kingdom, which was incorrect, she should have received group O. Next slide, please. I won't go into the detailed serology of it. The patient was absolutely fine, which is the main thing. But at the bedside, when the blood was being checked, the patient did actually notice that the blood bag was group A, or APOS, and questioned the nurses, and said that actually at Bristol, which was our transplant centre, that she should be having group O, but I can see that group is A. The safe bedside check was halted. The nurses liaised with our laboratory, and they advised actually to carry on with the APOS. It was fine as testing was done, and the blood was actually compatible. The scientist in our laboratory put the phone down and started doubting what they just said, and contacted one of our senior scientists who was at home just to double check what information was correct. And obviously the senior scientist at home said, no, they should have received group O. They contacted the ward and asked to stop the transfusion, but 5 mils had been transfused. Now, you might be thinking, well, that patient engagement didn't work and she still received that blood component. But actually, if that hadn't happened, I still to this day don't think we would have known that would have happened, because she probably wouldn't have had a transfusion reaction. I can't say for certain, but because of the serology and how she was blood grouping at that time, I don't think she would have had an actual reaction, and we would never have known it would. And it realised, and by the patient actually stating that, we actually realised what that error occurred, and patient was fine, but obviously quite upset that she felt like, although she was listened to, it still went ahead. So there was a lot of learning there, and it meant that we could actually review our transfusion process with our transplant patients and make it more robust based on the incidents that we found there. And again, this was just, I think I stole from Shruti and her team at SHOT, one of their amazing diagrams, which clearly includes, for these complicated patients in terms of blood provision, the importance of patient and family education about transfusion requirements. And the other local initiative is just what we found very, very useful is having a patient as like Anna. We've got a chap called Albert who sits on our hospital transfusion committee. I've grotesquely put his head on a Superman diagram there, which is my skills of artistic license, but he is a superhero. He attends all of our meetings. He sits as a patient representative for other meetings as well, not just our transfusion meeting. I've called him an influencer, which he laughed quite a lot about. He didn't think he was an influencer, but he is within our organization. He collaborates with myself and other professionals within our transfusion team with patient leaflets, policies, and is a patient's voice at a high-level clinical meeting. And as clinicians, we have the patient at the center of what we want to do, but it can be quite easy to get in the nitty-gritty of policies and process, and sometimes forget that there is a patient there, and he holds us to account at those meetings in case we're slipping down that line and we're sort of going off on tangents. So I can't stress how important and how useful, if that's the right words, to have a patient representative or lay representative on a transfusion meeting. Next slide, please. And then just really quickly, I'm conscious that I'm running out to time. Patient blood management is something that is a very much of a hot topic, and the role of patient safety partners in PBM is really, really important. Informed consent, shared decision making, as Anna explained, self-advocacy, and health literacy. So engaging patients are more likely to follow iron therapy, nutrition, and pre-op optimization plans. Next slide, please. The World Health Organization this year published guidance on implementing patient blood management to improve global blood health. And I was so pleased to see, I think it's the first of the 7 principles, I've copied the statement there, that towards eliminating avoidable harm in healthcare, also states that engaging patients and families as partners in safe care through shared decision-making is the first of the 7 guiding principles used to shape the development and implementation of the WHO action plan. So I was really, really pleased to see that. So I just wanted to put that on the screen. And then finally, like I said at the beginning, this isn't just transfusion and hemovigilance. You know, this kind of, the concepts of improving and engaging our patients with safety actually transpires to other areas of healthcare. So I've just put some random bubbles on the screen that sort of can really help and empower patients in other aspects if they're going to an appointment or if they've attended hospital and they've not got a wristband on, to listen to them and have their voice. So thank you very much for listening. I have put my email at the end in case anyone has got any questions, but I'll hand over to Shruti. Thank you.
Right, thanks, Stuart. Another excellent presentation to hear the clinical side of the situation. So our final speaker is Dr. Shruti Narayan, and Shruti is the medical director for SHOT, and she's also the IHN representative on the ISBT Hemovigilance Working Party. So thank you, Shruti, over to you.
Thanks very much, Simon. I really feel humbled to actually then follow Anna and Stuart as well, and they've really made my job very easy. And I think, believe it or not, all 3 of us have actually prepared and come to it from different perspectives and actually are covering the same. So this is actually going to be reinforcing things that are already being covered by Anna and Stuart. And I, again, wanted to actually start off similar to what Stuart did with an example as well. This is actually a case that was in our one of our recent annual SHOT reports. And this was a near miss where the patient's voice really actually mattered to ensuring safety. So here, if you see, a woman in her 30s underwent an emergency cesarean section. There was intraoperative cell salvage that was facilitated, and there was a blood loss estimated to be 900 ml. Now, at the end of that surgical procedure, the patient was then moved to recovery. And from that cell salvage process, they had actually produced around 226 ml of salvaged red cells. What then happened, they should have been continuously, transfused before the patient was actually moved. The anesthetist then took the labeled reinfusion bag, and they went to the bedside of what they thought was the current patient in recovery. The bag was hung on the drip stand and was connected to the cannula in the patient's arm. Thankfully, the infusion was not commenced. The doctor was then initially questioned by the patient, "Is that mine?" And then subsequently, the midwife also then said, "Okay, this was not the patient." And they then checked the patient's details on the label bag versus the wristband. And then it was identified that the doctor was in the wrong bay with a different patient. And it would have actually then resulted in an incompatible transfusion as well. So in this, the infusion was disconnected, removed, and therefore you could see how there was that timely intervention, and then the staff really taking note of that and rechecking the process as well. So the process was then also locally updated following the incident, where a patient receiving the cell salvage blood, they identified that should not leave the theater, without that red cell transfusion already connected and running. Now, there was another case where we had non-irradiated component administered. So this is actually similar to the example that Stuart actually mentioned. This was a female patient in her 60s with acute myeloid leukemia, who was admitted to the hematology ward for chemotherapy, and the patient was receiving a purine analog. And therefore, according to that, they should receive irradiated blood components. The patient had symptomatic anemia, hemoglobin of 76, and therefore the decision was made to actually administer 2 units of red cells and 1 unit of platelets. The units issued and transfused did not meet the specific requirements because they were not irradiated. That is because the laboratory had not been actually informed that the patient required irradiated blood components, and there was no flag on the laboratory information management systems, and hence standard units were issued. Actually, the patient had already been educated. They were informed that they needed irradiated, but although they asked the staff to check, this was not acted upon. So you see a good example and another one where we could have actually done better, because they then assumed that the components that were actually sent from the lab were actually the right ones. Now, we've already heard about all the benefits as well, and here what we are really aiming to cover through the discussions today is actually engaging patients not just at an individual level, but also the organization level, similar to what Anna and Stuart have actually then mentioned. And this was one of our key recommendations in the 2021 annual short report. And you would have seen the slide that in Stuart's slide as well, where we actually enhance that recommendation to actually say we need to partner with patients to enhance safety. And as part of that recommendation back in 2021 itself, we then had actually laid out different actions, what should be from the hospital senior management, so that they actually ensure that there is actually that enough leadership, the processes, the policies in place, and then how the clinical transfusion staff must then also have the necessary skills, the training to be able to actually then engage actively with the patients as well. Now, you may all be familiar that we produced the short transfusion safety standards in July this year. And again, the same recommendation, because all of these were based on the previous recommendations as well. This figures as one of our standards. In that standard number 6 is actually patients as safety partners. And in that, we actually go through in more detail. You could scan this QR code to actually go to our the standards document as well. And all of you may be familiar with this kind of a framework for safe transfusions, where you're actually really ensuring that the right component is given by the right staff to the right patient at the right time. And we really are focusing on that right approach, that we need that patient-centered approach. We need that good communication as well, and ensuring a good patient experience. Now, this is a systematic review. I'm not, I've put the link there, but essentially, the bottom line is once we work closely with the patients and the families, we know that the healthcare system is actually safer, patients have better experiences, and they also have improved outcomes. I wanted to clarify a couple of things. We may hear different terminology. You would hear patient engagement, involvement, partnering, and co-production. It is basically a continuum. I have it on the next slide. Now, really, co-production is actually that specific type of engagement, which is actually transitioning from doing things to and for people to doing things with people. So it is actually more a range of a continuum that you would actually be seeing. Now, you can see here the level of engagement, where inform is more in the passive end, whereas you're consulting and then partnering from a low level to actually more a high level partnership and collaboration and shared decision making. Now, what we really need to understand is all engagement levels are appropriate depending on, there are different factors that we are actually at play here, some of which we've already covered. And basically what we really need to be doing in all these situations is engage with the families and patients and carers. And we need to be then determining together with the care providers and leaders what is the most appropriate level. And this is actually a paper from Canada. I've signposted this, where they have the patient engagement action team, which came out with this. And we've also learned about different ways in which to engage with patients and families. And they can be in the form of both quantitative and qualitative, and some of which, Stuart had amply demonstrated as well what they have done in their hospitals. So whether it is actually through surveys, feedback mechanisms, also through consultations, interviews, focus groups, and patient stories, to actually really inform us how can we do better. Now, I wanted to highlight a few key things that we need to note. First, this is not something special that we actually do once in a while. It should be embedded into our day-to-day practice. this should be proactive rather than actually reactive. So how can we think of prospectively in every one of our process? We also need to actually have effective leadership and accountability surrounding this engagement and the co-production as well with the patients. But we've also seen that this is not going to be an easy path. There may be different approaches. It's not one size fits all. It is actually taking into consideration, the cultural sensitivities, the challenges of language, the terminology, and the health literacy as well. And therefore, that is where we need to actually also ensure that we have our staff who are actually trained to actually then engage in these constructive communications. Now, this is actually from the Patient Association in UK. What they came up with is the 6 key principles of patient partnership. Now, this is all what we have actually heard already. First is treating patients as equals, ensuring that the patients are fully informed, and understanding that this is actually a shared decision making and partnership with the patients, recognizing inequalities and ensuring that there are appropriate approaches, and seeking that active input, genuinely valuing the input, and also you're meaningfully acting upon them. It is not playing the lip service. It is not doing a tick box. It is actually then maintaining those feedback loops and how have we taken that into consideration. And also making sure that we are joining up the services around the patients. What are the patient's needs? How is the patient flow as well? And I think a bit of this, Stuart has already covered, because you may be familiar with this 10 steps of the transfusion pathway. This is at the hospital end. And over the next few slides, I'll quickly run through similar to what Stuart has actually done. So hopefully would reinforce what are the different opportunities. First, when you look at all the steps in the pathway, we would look at in all these different steps, making that decision to transfuse, sample taking, administration and monitoring, and all the communications related to the transfusions, as well as if there are any safety incidents as well. So in that decision to transfuse, we need to ensure that the patients and carers and families are actually provided that necessary information, and engage in that healthy, welcome the constructive discussions about, do I really need this? Is this really the best option? Are there any other alternatives? What are the risks and benefits? But also encouraging them to actually understand the importance of telling us anything about their past transfusion history, about reactions, about any known antibodies as well. And in that sample, ensuring that the engaging with the patients, asking them to challenge if there is actually and the process has not been followed. Samples, have they been labeled correctly by the patient side? Having that positive patient identification, participating in the safety checks, like what Stuart actually then said as well. And in administration and monitoring, we then do, again, patient identification checks, asking questions about what patients can and can't do. So these are different ways when somebody getting a transfusion can actually then understand. How should I feel? What should a normal transfusion look like? What to expect? What are actually the red flags? And making sure that our observations are actually taken regularly. And monitoring how a patient receiving a transfusion would be actually then feeling, and also ensuring that patients are comfortable to actually raise any concerns if they're not feeling well. If it is actually outside of their normalcy, then can we actually then see whether or not this is linked to the transfusion that they are actually then getting both during. And remember, delayed complications can occur as well, and therefore it is really important for them to be actually aware this can happen. And it's also important that my urge to you is, after today, to go back and actually then check, how do we include transfusion related information in the discharge communications as well? GP refers to the general practitioner, so it could be the family physician equivalent. Also post-transfusion information as well. And also one step further is, if there is any transfusion safety incident, so, then how do we welcome that participation, keeping that duty of candor, keeping that transparent and understanding? So how can they participate and provide information and share insights as well? Now, this is actually from a paper from Professor Mike Murphy and colleagues, and also Charles Vincent, where they actually then said a degree, something that Stuart and Anna both actually then covered. The degree to which a patient may be actively engaged depends on multiple factors. It depends on their awareness of how to be involved, their ability to actually then participate, depends on their physical and cognitive capacity, and their willingness to participate and take on an active role. And therefore, it is that shared discussion and deciding what is actually the engagement level. Again, to emphasize, whenever we are actually saying partnering, it does not take away the responsibility and accountability of delivering safe care, which still remains in the hands of the healthcare professionals. And patients should not also feel that if they do not wish to contribute, or if they are unable to contribute, this should impact their care. No. as I said, this is actually adding in another layer of safety, but it does not actually then, if they are not in a capacity to actually then contribute, does not actually cause any detriment to their own care. And we should always be actually, as healthcare professionals, encourage that involvement, but avoiding that pressurizing the patients as well to partner. And, it is also important that patients taking ownership of their care, again, does not diminish the responsibility. I'm glad, Stuart has already covered this, so I won't dwell on this. This is actually the WHO, and they brought out this framework for action, the 7x5 matrix, and again, there highlighting that importance of patient and family engagement. And all of you may also be aware the infected blood inquiry report that actually then was released in May 2024, again, covered in a big section about giving patients a voice. It was actually talking about all the past incidents where information and consent, where people were not warned of the risks, misleading the assurance. Also highlighting the importance of the shared decision making, which we have now updated the consent guidance in the UK, and understanding, how do we communicate the risk to the patient? If there is an information overload, how are we actually then giving that in piecemeal and ensuring that they are able to grasp, able to actually understand? And also at every step. So, if you're from a blood service, also understanding how can we engage with blood donors through all the different steps, both in our policy making, in our research, in our different, processes, and also in any brainstorming sessions. So how can we work with them to actually then develop the resources and develop the services for them? Now, we do have a patient page on the SHOT website. Please do scan this QR code. And we have, again, worked with patients to actually bring out an aid memoir, and this is actually from a few years ago, nearly, I think, 2021, that we actually released this. Please have a look on that. And if you scan, that would take you to the information page on the SHOT website. The app has already been covered, and it has really been a pleasure working with 8 patient representatives. And they brought a completely different perspective. It is actually understanding what are the important questions that they want answered when transfusions are happening. It's also a useful resource for healthcare staff taking the consent from the patients as well. And remember, at the end of it, it is well-informed patients make better choices and have better outcomes as well. Now, all resources from SHOT are also available on the SHOT app. So please do, download the app from the App Store on any of the smartphones. So I think I just wanted to end by a couple of, key things. We're all on this journey, and it is really important. What are our enablers? What are the drivers? What are the challenges? But also recognizing what are the opportunities for change. And it is identifying and working with patient representatives, always starting at some point to actually then say, what are the tactical change ideas? What are the key issues that we need to actually then address? And they are really strong voices. So even to actually help get the necessary funding, get the necessary resources as well. And always ensure, anytime that we are talking about a supply chain, blood components, blood products, remember there are actually humans, there are people focused, maintaining that people focus. There are donors from whom blood has come, patients to whom the blood is going, and staff who are actually then in between all along in the journey of the blood and the patient care pathway as well. And what we really need to see is, it is how do we build systems which are effective, which are reliable and resilient with the feedback loops, because we may not have got it right all along, but ensuring that they're able to actually communicate that I think we could have done this better. And how can we actually then, learn and improve our practices is really important. And equally, like this forum, it is important really to actually then share our experiences and lessons learned, because every time I hear, from Anna and Stuart, I learn a bit more about what can we actually do, how can we shape things better as well. And so I think really, at the end, I just want to actually say that safety is a team effort. And in that team, we have, a variety. It is multidisciplinary, it is clinicians, nurses, doctors, scientists, quality leaders, patients, donors. All of us really need to be working together to actually then enhance safety. So again, thank you. And I think we can, willing to take some questions as well. Thank you.
Brilliant. Thanks, Ruthie, for completing the circle, if you like, on the 3 speakers or the 3 talks. That's fantastic. So I'm not seeing any questions in the Q&A, so I'm not quite sure whether or not there's a block there. I just wondered whether if people want to, if people raise their hand to indicate a willingness to ask the questions, are we able to unmute if people raise hands, or is that something we can't do?
I think there is a comment from Erica. Thank you, Erica, for joining.
Oh, it's just appeared. Sorry. Thanks, Erica.
Yes, sorry. over to you, Simon, if you want to read that.
Yeah, so thanks, Eric. This is great presentations. Thank you to all. That's much appreciated. Could the speakers share some practical tips or specific examples to help patients and families prepare to speak up and to help clinical and laboratory staff be ready to engage with patients when patients do? It's easy to say, but for some people hard to do. Sometimes people are quite cautious or anxious. The example of the patient who had a transplant was great, and more examples would be really helpful. That's from Dr. Erica Wood here in Australia.
Yeah. I think Anna and Stuart, do you want to actually take that first and share from your perspective as well, because you're more in the hospital end, and it would be really useful to hear what you'd like to actually then say as well. And thanks very much, Erica, for joining us.
Yeah, so shall I go first? Thank you for that question, and it's a really great question. Something that in all my involvement work that I do, which is also not just with NHS blood and transplant, I also work with blood cancer patients, blood cancer charities, cancer research charities and things like that. So it is something that's discussed a lot amongst these groups, and I think the message to get across to patients, families, is that there's no such thing as a silly question. I think I agree with your comment that people feel, for lots of different reasons, unable to question anything, unable to ask sort of questions. And I think we're doing a lot of work with charities in the UK to try and change the perspective on this, so people do feel like more comfortable asking questions. And I think it's probably something that's not going to change overnight, but I think it's about educating both the healthcare staff and patients that you can ask questions. I think when I was going through it, bearing in mind I worked in pharmacy as well before I worked in a doctor's surgery, I didn't feel I could ask questions. So I think we need to do a lot of work on through sort of patient groups, charities and those kind of things, organisations in our countries, to get the message across to patients that, you know, it's okay to ask questions, you can ask questions, and for clinicians to be more asking patients, do you have questions? That was my first sort of thoughts on that that question that you had there. There's been lots of work going on in the UK about it, and happy for you to contact me for if you want to after today as well.
Yeah, I not much to add really. In addition to what Anna has just said, I think that education is really important, and it can be quite hard. I know, you know, when I've spoken to a few patients who've been involved in deviations or errors, and we're trying to learn from it, and you know, where they didn't have a respondon, or they you know, and they might have actually known that but didn't want to raise that because, you know, they trust the professional, they don't want to be that annoying patient that speaks up and interrupts that process. And I think it's just changing that culture, and it is quite tricky, and it takes a bit of time. And I think things like the transfusion app, having digital resources there can really help, because that's what I quite like about the digital app that we've got for patients now, is that patients can have that all the information there and read it in their own time at their own speed, when they want to read it. And all the information in there is really powerful. And then that I've read it, and I've read the information in there, and it can really help empower you to do that. But then it's like, yeah, Anna said, that education, but then, you know, doing that with friends and family as well, when the patient themselves might not be able to speak up. So yeah, education is key, and I think I would agree with Anna there.
Yeah. And I think if I can just add to that, thanks, Anna and Stuart. And I think one of the things I'm just reflecting from a healthcare professional perspective as well. I think there was also a paper when they did the a survey of how confident you are to engage with the transfusion recipients. And I think there is a big phobia. There is a fear whether I'll be able to answer the questions relating to the transfusion risk. So I think the process should also start with actually educating our own staff. Are we, you know, and there's a bit of, when they're approaching the patients, I hope they don't ask any questions because I may not know whether I'll the answers. So I think it is a bit of, when we talk about education, it is actually both about staff, getting them more confident and be able to answer, but equally having that humility to actually say that I don't know, but I'll find that answer for you, and get the relevant people to come and then answer the question for you. And I think, you know, being a patient as well, you then understand that all you want is actually clarity and that honesty. And I think that integrity. So I think you're building those opportunities, and we are talking there at individual care levels. But what we're also actually moving towards is pushing it more at an organizational level, from an organizational safety and policy. And so, like what Stuart has actually then shown, can you build and create those opportunities, whether in a hospital transfusion committee meetings, inviting somebody who can, and it is not just somebody who is coming in. So there is an onboarding process that we need to see. How do we actually then engage and invite them to participate? Also, whether there is any remuneration for the time that they would be actually spending as well. There may be frameworks already present in your country, for that, and having a debrief as well afterwards, because I think it's really important to actually understand, how did that go? How did you feel? Did you feel confident to actually then voice your opinion? Because again, one patient voice in a big committee, are we actually making it safe? Is it psychologically safe for them to actually then also express? So having that onboarding, having that debrief, having certain frameworks, which is actually then allowing them to adopt that across in all the organizations, would be actually really useful. And I think where you start, then you're learning and then actually building it on from there. What worked, what did not work, and getting their feedback.
I have a follow-on question about the app, and I just wonder, I'm not entirely clear how many places it's been implemented, but there are a couple things that are people questioning, like with that additional information, are they asking, actually using the app to ask, why am I getting a transfusion? Or are they more afraid of a transfusion reaction because historically they'd get a piece of paper, they'd sign off, and they never look at it again? But now they have an app, they can look through all the complications. Are you seeing challenges to this, or is it working, but is it working in the way you expected it to?
Yeah, I think we only went live with it July. So I think it may be a little early, but maybe Stuart would be able to actually then come from a hospital perspective as well, Bobby. But I think the whole process it is nearly 2 years of work with 8 patient representative when we actually came through. One of the things we were also conscious is they're all patients, majority of them had received multiple transfusions. So as part of user testing, we also went to transfusion naive people to actually say, what is the language? How can we actually then address that? Now, what we are hoping is with this app, it is actually inviting those questions. And we can't just say the app alone is responsible, because again, with the infected blood inquiry, various other mechanisms through patient blood management, we are really making sure that patients are questioning, is this the right choice? As we say that the safest transfusion is the one that did not happen. So I think it may be difficult to actually relate what the impact is so early. We've had more than 1,000 downloads and people actually actively using the app. And I think only time will say what the true impact is. But Stuart, I think, have you noticed any change with people actually using the app?
Yeah, it's early days, Barbie. So if you ask me that in 6 months, I might be able to come back with a more of a robust question. It was something that we discussed when we were talking about the app and implementing it. So we have launched it, if that's the right word, quite softly within specific areas, just to get a feel of how our patients are seeing it. So we've launched it very softly within maternity, primarily because, not to be ageist at all, but they're a younger population and more digitally minded, so they will be more actively using it, so we can get a bit more feedback quicker. So I agree with Shruti. It's just too early days to see if we are scaring our patients a little bit too much with too much information. But time will tell.
Great, thanks, Stuart. There are a few more questions, but we are running quite close to time. So maybe one quick question, and then I'll hand over to Barbara to close. So, and the questions we haven't got time to answer, we can probably answer those offline by email, so we can certainly get back to you. So the last question is from Haram Tariq. Is there anything we can do at blood bank level for enhanced patient/donor involvement? So I guess that's the other thing. The patient's voice is one end, but we don't perhaps think of the donor voice. But so is there anything we can do in that regard? Anything we do at blood bank level for enhanced patient/donor involvement?
Yeah, And I think another great, so one of the other hats I have is actually as a donor consultant, and within the donor medical team, one of the questions we always actually look at is how can we partner with donors more? Now, we are not doing enough, and we need to really be doing more, with respect to the donor screening forms, the health questionnaire, the consent, engagement, and getting more donors as well. Because one of the challenges that we really have is A, we do not have enough donors to match the demand, and B, we may not actually then, and this is, I think, a worldwide problem about how do we actually improve the ethnic mix. So we are actually getting variety of the donors from different population to meet even the needs of our recipients as well. So I think there is a lot that we can actually do. And I think, again, in that question is actually first and foremost getting a group of donors who are interested and who are willing to actually then contribute. And then again, engaging at all these different issues. So it would be useful to actually have this kind of a brainstorming, a blue sky thinking kind of a mechanism where you're really welcoming opportunities for collaboration. So starting with, say, we are looking at our consent for donors, and then we can actually then say, this is the wording, but also co-produce with donors. This is the language. This is what we are actually asking. Are you understanding what we are actually then saying? How better can we actually give that information? So I think, again, there from that donor journey, we can actually be engaging them more. But there are also other ways, like in the UK, we have the Harvey Gang initiative as well. So if you're in a hospital transfusion bank, how can you actually then improve the visibility? Because for us, the important thing is, yes, the patients and families may only be seeing the clinical teams, but hidden behind that through the journey of blood is actually really important, laboratory colleagues who are actually then doing all the work. And how do we meet our hidden heroes? So I think making that part of the pathway as well visible, and taking the patient representatives to actually then see them, to understand what happens to your blood sample, where do you get the blood from? And I think that again improves. So there are lots of initiatives and lots of opportunities to go there. And it is actually just thinking of any issue, and always an automatic question for your stakeholder should be, can I have a donor or a patient stakeholder?
Great, thanks, Shruti. Well, we've just sort of run up against the hour mark here, so we're just a little bit over. So just hand over to you, Barbara, to close up for us.
Thank you, Simon. So thank you, Anna, Stuart, and Shruti, for very nice presentations. I feel that you gave us a lot to think about and a lot of tips to improvement our practice. And on the end, we would like you to look on a little bit poll or survey about the question or questions, short questions about the IHN. Can you show it? Yeah, wonderful. So this is just a couple of questions about the fall webinar, and we'll be very pleased if you can answer them for us. So we have a little bit overview. What do you think about the webinars? Yeah, so that was for us. I don't know, Simon, do you have any other closing words?
Well, just really thank you to Anna, Stuart, and Shruti for 3 wonderful presentations. Thanks for people who attended, but it's always great to have you come along. And thank you very much again for Raquel and Darren in the background, keeping us on air and keeping us going. So thanks, everyone. Good to see you all, and hopefully you'll join us next time we host the webinar. So thank you.
Wonderful. Thanks very much, everyone.
Thank you. Bye-bye.
Bye.